I'd like to thank the AIOC for inviting me for this talk on expanding the horizons of astigmatism with toric IOLs in our practice. Now, toric IOLs have been there. All of us have probably used it at some point in our lives, and some of us are using it routinely. And it's an extremely successful tool, probably one of the best lenses that has ever come into the market. But we want to understand whether we can extend this comfort of toric IOLs and the advantages in eyes which have certain pathologies. Let's start with pterygium. Now, pterygium is so common in our part of the world, and particularly pterygiums which, when they turn up, are atrophic. Pterygiums that are atrophic do cause temporal drag of the cornea, and they cause a very typical and a very irregular sort of an astigmatic profile, which is called typically a coma. And a coma is a bad aberration because a coma is not correctable with anything. No spectacles, no IOLs can correct coma. And this is not a suitable candidate for a toric IOL because the basic prerequisite is to operate in a regular astigmatism. But what happens when you do a pterygium removal in your clinic? If done well, and if it done in the right plane, notice how the entire coma vanished away into a regular astigmatism. Because the cornea that was pulled on one side has now been left and it's become fully round and regular again. Just to show you pre on the left side and post pterygium excision on the right side and how an irregular cornea turns into a regular cornea. Now this patient does have a good astigmatism profile, and so we counsel this patient that they will need a toric IOL, understanding the fact that they might have surface symptoms secondary to pterygium removal, and they may be on, and we counsel them to be on lubricating eye drops for an extended period of 2 months. And needless to say, the patient was very happy, unaided 6/9, which is something we otherwise would have not promised the patient and been wary of, considering the pterygium and the irregular astigmatism. But then there are more challenging cases. There's the refractive surgery eyes. And I've never seen an RK happen, but I see a lot of post-RK patients that come up in our belt. And these patients are not all of them are bad. In fact, some of them are good. Some of them are astigmatic, but regularly so. And with this patient, I wanted to understand what we learned, in our clinics, was the fact that what we're treating is just the pupillary cornea. We don't treat the whole cornea when we operate with the cataract. Only the part that where the light goes through to cause that refractive correction is what we treat. So if the patient is regular in the pupillary area in his astigmatic profile, I think it's a good candidate to put a toric IOL because the rest of the cornea does not matter. We did counsel this patient of surface symptoms because RK incisions can split open at any point in time, particularly with higher IOP surgeries. And we did tell them that there is no guarantee of distance spectacle freedom because no matter what IOL calculation formulas, you can still go wrong. And the fact that there may be some optimal. We use the IOL calculator that's available at the ASCRS for free, so all of us can use it for all refractive surgery, post-refractive surgery eyes. When we looked at this patient at the 3-week follow-up, unaided distance was 6/9 parts, which is very good considering the fact that it was a previous RKI and reaching target is difficult in the first place. So we were able to hit target with the biometry, the calculation, and the astigmatism profile, and all the patient landed up was a minus 0.5 diopters. The best thing about RK patient is one RK patient sends the second RK patient because they all have a cohort and they all talk and what they did right or wrong in life. This is just to show you how the lens looks well centered and stable. All these patients in our clinic are counseled for suturing these incisions because time and again they can open up. And this is how the IOL looks well centered. The more sinister problems are retina and glaucoma. And this is a gray zone, whether we can put a toric IOL in a glaucoma eye or whether we can put a toric IOL in a glaucoma operated eye. And this is just, again, a patient, 46-year-old, open angle glaucomas with had trabeculectomy is done. And after a year of trabeculectomy, had a secondary cataract for which she had to undergo cataract surgery. This is the profile of the patient, 1.6 diopters of regular corneal astigmatism, as can be seen on the trace over here. And just to show you in a larger perspective, the IOP is well controlled, and this is a bad field. The superior arcuate part is almost gone. The inferior one's already building up. And the question is it right to do this IOL in this patient, or is it not right to do this IOL? Macula is okay, so the OCT is unremarkable. We did counsel the patient of suboptimal vision, and with the 1.5 diopters of astigmatism, with a glaucoma and a field that's like that, the contrast is already down. And if you have to wear spectacles, you are going to drop the contrast by an additional 10% or more, considering you have another frame in front of the eye. And so we counsel the patient that they need a toric IOL. And so with this, they can enjoy whatever best corrected vision they have without depending on glasses. 6 months, patient is good, unaided visual acuity is 612, partly related to the glaucomatous optic atrophy. The patient does not accept any refractive correction because there is none to give to the patient for distance correction, and the patient is happy. And so I guess with these, this is how the patient looks. It's an old trap with a large PI, and you can see the toric IOL sitting well. I mean, you have to understand that the PI has to be covered by the lid margin, and with that, this thing I think is probably one of the advantages of a toric IOL, that it's just a monofocal lens with an added astigmatic profile. And if you can take off that much handicap from the patient's eyes, particularly in diseased eyes, I think there is no harm in putting these lenses in these patients. And I think in our hands, it has worked out very beautifully for these eyes. So a take-home message for glaucoma is it can be considered. I mean, you have to look at it clinically. You have to be a good clinician and understand the pros and cons. So even for ARMDs, early AMDs, and early diabetic edemas, diabetic retinal changes, I do prescribe toric IOLs to these patients. And to come up with the pediatric eyes. Now this is again a gray zone of whether we should use toric IOLs or not. And a lot of literature has been published over the years that suggests that the cornea, the curvature of pediatric cornea tends to stabilize by 3 to 5 years of age. And you only change when you're old because your collagen breaks down and you go from with the rule to against the rule astigmatic profile. In children, needless to say, you have to combine it with the posterior capsular excess, and you have to follow up these patients to rule out any visual axis obscuration. And just to show you how the patient looks 6 months and 6 years at follow-up, and we have a long-term follow-up of these patients with pediatric toric, and they do very well. And it's also important because pediatric, if you treat astigmatism, the chances of amblyopia and visual rehabilitation is faster. Just to end up, sometimes you get cataracts, which are very interesting. So this is a patient who came up to me with an air blower that hit his eye. And at 3 weeks, this is what it looks like. The posterior capsule is split up open, and there's a cortical cataract in a young patient developing, like so. We decided to do a femto delineation, just like we would do in a polar cataract. So we use femtosecond laser in this to create a rhexis and to create rings so that we don't have to do any hydro maneuvers inside the eye. And I'm just going to move out of this because it's not the purpose of the talk. But once you make rings, it's easier to debulk the nucleus. And once you debulk the nucleus and use moderate parameters, particularly in eyes where you're able to preserve that PCR and not enlarge it and maintain the integrity of that PCR, you can put a toric IOL considering your bag is stable. So in this patient, considering that the anterior vitreous phase was not ruptured, because we used the right parameters, we went slow. And more importantly, the PCR margins were round and fibrosed in 3 weeks. So we had a hope that the PCR does not split. We were able to place the lens very comfortably, as you can see, inside the capsular bag. And once the lens settled down inside the capsular bag, and your part is done, you know this lens is not going to move, and a bag is a natural compartmentalization for the lens in any case. And so it can be considered if you have traumas that have ruptures of the anterior or posterior capsule, provided you realize that there has to be a 360-degree cover and there has to be no sharp edge. And with that, I'd like to end the talk. That in our clinics, now that we have used toric IOLs for so many years, I think we can expand the ideas, we can expand our horizons, and look at that one odd patient that can do well with the toric lens compared to a monofocal.